you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Hello, everyone. So if you're an EM Crit listener, you just finished listening to January, which I thought was adorable. Airway all month for January. So here on the Ultrasound Podcast, we're having SMACC, or SMACC. We're playing videos from SMACC in February. We're not as creative as Scott. Doesn't mean we can't rip off his idea of themed months, though. So your first one here is a talk I gave at SMACC last year.
Hi, I'm Ollie Flower.
I'm Roger Harris.
And on behalf of Chris Nixon and the rest of the SMACC Organising Committee, welcome to the SMACC Podcast.
Nope, you're not listening to the SMACC Podcast. You're listening to the Ultrasound Podcast, Rip-Off Edition. We've stolen the SMACC Podcast to replay for you since it's me. This is my talk from SMACC last year. We've added the video, so it's not just audio like on the SMACC Podcast. Roger and Ollie, back to you and your sexy Australian accents.
First up, save the date for next year. SMACC Chicago, June 23 to 26, 2015.
Chicago is one of the coolest cities in the world. It's got bars, clubs, it's got the food and jazz vibe going. And in terms of popular media, who could forget shows like ER and Ferris Bueller's Day Off? ER, actually, I'm feeling a bit like kneeling down and air punching right now.
You're more of a Mark Green than a Benson, I reckon.
Gosh. Anyway, get yourself to Chicago, go to smack.net.au, book your leave now, and we'll see you there.
Good afternoon, everyone, and thank you to come into this afternoon session. My name's Lewis Mackin. I work in intensive care at Royal North Shore, and you are at the ultrasound session where we're going to look at the future of ultrasound in critical care. A little change to the running order. We're going to get Matt to kick off before Mike, just so we can sort our little laptop issue at the back. So without further ado, we're going to get Matt Dawson to come and speak to us first. He needs no introduction after extravaganza of yesterday. So can you please welcome Matt Dawson?
It's not often I have something positive to say about Dawson on the podcast. Compliments aren't really, our thing. But I'm not sure there's a way to say anything negative about this particular podcast. Matt sent me this talk from SMACC 2014 at the Gold Coast for edits, and I can't really find a negative thing to say. I was there. I remember the talk. I remember how damn good it was and how nervous I was about having to speak after him to try to bring the crowd back from their state of awe and Dawsonification. So when I introduce him this time, I'm not going to make fun of how he talks like that guy from I'm not going to insult his intelligence by comparing him to a small I'm definitely not even going to mention that time he took a in front of a bum in Portland. Instead, I only have positive things to say this time about Matt Dawson and the amazingness which he recorded at SMACC 2014.
Thank you, Lewis. So when Chris Nixon first asked me to talk about pediatric ultrasound, I was not happy. All right, I wanted to talk about something really cool, like the future of ultrasound. You guys know what I'm talking about. Handheld probes that wirelessly Bluetooth to Google Hangout, really cool stuff. Built-in accelerometers in the probe, image recognition software so that it could actually tell you how to move your hand in space to get the perfect type of image, gives you percentage of likelihood of diagnoses, almost to the point where you could have a consumer ultrasound, a few $100s in a first aid kit that you could pull out at any time. You slip on the ice, hurt your ribs, you think, is this a rib fracture, is this a pneumothorax? You got your probe, you Bluetooth it to Hangout, tells you how to move your hand, gives you a percentage likelihood, you're still not sure, just Google Hangout with your physician or an ultrasound expert. They can see exactly what you're seeing. Really cool stuff. That's what I would like to have talked about. But we've got people much smarter than myself talking about the future of ultrasound. And Chris, in his great wisdom, said, this stuff is probably 5 to 10 years down the road at best. Why don't we give them something that they could use next week and apply in the pediatric patients that they're seeing next week, or maybe even tomorrow where you're working. So we're not going to talk about any of this futuristic stuff that would have been really fun. Instead, pediatric ultrasound. And I got to be honest with you, pediatric ultrasound, it used to bore the snot out of me. It really did. The key word there is used to. It used to really bore me until I had kids of my own. All right, I understood kind of the benefits of pediatric ultrasound, but when one of my children got really sick and ended up in the ICU, that's where I really saw the benefit, and it really came home to me. I knew that these kids you get incredible images. They're almost like MRI pictures sometimes. They're little, and we talk about radiation exposure all the time, and these are really the people where it really makes a difference. To be able to do ultrasound on these kids, that's where we could have a real benefit. But it definitely took my child, Avery, the smaller one there that you can see, it really took her getting sick for me to really take this to heart and get motivated enough to actually learn how to do some advanced pediatric ultrasound. So I'm going to get a little personal with you and tell you this story, because it's a story that motivated me, and I hope that it motivates you as well to see how important this is and to learn this skill. This is Avery now. This is her when she was a few months old. She's a perfect baby. She's laughing all the time, very happy baby, until one day she started not feeding well. It was just a virus, we were sure of it, nothing else. But she never really spiked a fever. It never didn't really make sense. And every day she started getting a little worse. Until a few days in, my wife and I became convinced that she had botulism. And my wife's a physician too. She's a child psychiatrist, which you're probably thinking explains a lot about me. But we had never seen a case of botulism, and for some reason we thought that she had it. It seemed to be the classic signs. We waited for a little while, and finally she got dehydrated enough that we decided to take her in to the emergency department. Obviously, they told us we were crazy, that no, it's not botulism, but they humored us. They called the pediatric neurologist down. He said, no, she's not floppy enough. It's not classic. It's not botulism. So that's fine. You're going to be wrong 1,000 times if you guess that. So they started to look for more common things. And they started with just a urine. Maybe it's just a urinary tract infection. They wanted a catheter, but that concerned me a little bit because I knew she was dehydrated. She hadn't been feeding at all. And I know it's not a big deal to get a urine cath on a baby. When it's your baby, it's kind of a big deal to assault the urethra like that when you're worried there's no fluid in there. But what are you going to do? The only way to know if there's actually urine there is to go ahead and put the catheter in. Well, of course not. Obviously, I wanted to look with ultrasound and see if there's anything there. I bring up this because I think this is one of the small things. I hear people talk all the time about pediatric ultrasound and not really wanting to do it because there's no real evidence for it. And that's true. There's no real evidence for much that we do in pediatric medicine, period. There's not a lot of great evidence. But those of us who use ultrasound, there's 100 little things like this, like looking to see if there's fluid in the bladder before you put the catheter in. 100 little things that make a difference, small differences that add up in the care of our small and vulnerable patients. So again, they humor me. This is the emergency department where I work. So I knew where the machines were. I kind of knew how to turn them on. They let me take a quick look, and this is what I saw. She actually had a huge distended bladder. Now, this actually kind of confirmed in my mind, as twisted as that may be, that this is botulism. I thought she was dehydrated. She hadn't peed in over a day. And now suddenly, I think this is definitely neurologic. Everything's kind of making sense. So I think this was the first sonographically confirmed case of botulism. So I was honestly so convinced at that point that I Googled the number and called California, which is the only place in the U.S. that makes the immunoglobulin, and asked them to go ahead and send the medicine to Lexington. An interesting thing about that is that when the pediatric neurologist doesn't think it's botulism, it turns out that a second opinion from the dad isn't good enough for them to fly a medication that costs $40,000 a dose across the country. So they weren't happy to send it to us. Another interesting thing is that if you work at a university and you have a good enough relationship with the residents, you can convince them to do about anything. So somebody did order the immunoglobulin at that time. And I still remember the look on the peds neurologist's face the next day around noon, when by that time they had actually decided that it was botulism. When he agreed that it was, and we said, oh great, the immunoglobulin arrived about an hour ago. Is it okay if we give it to her now? So that was kind of a priceless picture that I'll never forget. They started running into problems though in her workup that first day. Avery is what we call in the U.S. husky. All right, she's never met a food that she didn't fall passionately in love with. And while these rolls are adorable on a baby, it's not quite adorable when you're trying to get IV access. They poked her and just couldn't get IV access. And this is really frustrating to someone who knows the literature on ultrasound-guided IVs, when no one taking care of her actually knew how to use the ultrasound to get an IV. And when you know this literature about how it may make a difference, change the success rate in a difficult patient from 33% up to 97%, it can kind of drive you crazy watching them continue to poke. It's not that much of a slam dunk in kids. That's an adult study. But even in the pediatric literature, we've got good studies on this. In this study, they decreased the time to cannulation from 7 minutes down to 1 minute. The number of sticks from 2.5 down to 1. And you're probably thinking right now, well, if you look at the overall success rate, it didn't really change much, 90 versus 85%. So is it really that big a deal, you may be saying, to poke a few more times? Well, if you are saying that, don't say that loud enough for me to hear you, because I was looking at my daughter's face as she was getting poked several times. I think this is a very important skill to have. So this is how you do it. Here's a long axis view. You see a beautiful vein there. You all probably all know how to do this just fine. Get a beautiful needle coming in. You see the whole needle. You see the tip in the middle of the vein. Now, once you're in the middle of the vein, you can go ahead and cast the catheter off, and it's just a really nice confirmation. You can see the entire catheter in the length of the vessel. You know you're in this vein that you couldn't palpate or see beforehand. Alternatively, you can do the short axis approach. You could never have seen or felt this vein on this patient without ultrasound. Here we're watching the needle tip come in. We identify it above the vein. We're sliding the probe distally as we continue to place the needle further in. We follow it, track it all the way, just the tip all the way down to the vessel. Right on top, we see it tinting the anterior part of the vessel, pop in, and then we slide the catheter in. Obviously, it's not this easy. You can't just watch this and think that you're going to be able to do this. This is like every skill in medicine that you ever learn. You have to go home and practice it, but I'm not going to spend a lot of time on this. I do know two things about this, though, about ultrasound-guided IVs. I'm very certain about two things. Number one is you can do this. I've trained hundreds of people to do this. This is a skill that everyone can learn. Some people learn it more quickly than others, but everyone can learn this. And the other thing that I know about this is that it's worth taking the time to learn this. Our patients are worth you learning this skill. If you take care of kids and you don't know how to do this, learn how to do it. If you do know how to do this, then teach someone else how to do this. I never place an IV anymore, an ultrasound-guided IV, without grabbing a nurse or resident and showing them how to do it, because I've seen firsthand the difference that it can make.
If you don't know how, just Google Ultrasound Podcast PIV. We've covered it.
They couldn't get IV access on Avery, and they ended up placing a subclavian line. It's kind of a hard picture for me to look at still. She had a subclavian line, and this is a difficult thing to see happen when you know you have a baby that has a completely reversible course, botulism. It's going to get better as long as we don't have iatrogenic injuries, and you know the complications that come along with a central line. Luckily, we know that ultrasound can decrease some of those complications and risks. And I'm not going to go over any of these 38 studies showing how ultrasound improves vascular access. You all know that. That's a very basic thing. But Avery actually had, if you saw, she had a subclavian line. It wasn't an IJ. You can see it running right here. So not much benefit for her with ultrasound, right? I mean, subclavian lines we placed using the great landmark of the clavicle. When I was a resident and even an ultrasound fellow, I never did one single ultrasound-guided subclavian. I thought it was kind of a waste of time. You've got a great landmark. Why bring something else in to complicate it? Then after I finished my training, this study came out. It's a pretty amazing study. Over 400 patients prospectively randomized in an ICU to have ultrasound guidance or landmark guidance for subclavian line. The results were remarkable. When you take a look at their overall success, went from 87.5% to 100% in the ultrasound group. The pneumothorax rate, which we're really looking for, 4.9%, 5% down to 0%. And all of these complications they recorded, those numbers are smaller on the left hand than on the right hand. So after seeing this study, yes.
Supraclavicular or infraclavicular?
This is infraclavicular. Yeah, great question. This is the infraclavicular subclavian line. So after seeing the study, to be honest, I can't really justify not using it in a non-crashing patient. Obviously, a crashing patient, fine, landmark technique. In a non-crashing patient, this seems to make a difference. And 5% pneumothorax rate, that's 1 in 20. So that's pretty good. 19 patients are going to be totally fine there. But if that one patient that then gets it after every 20 that you place, how do you think they're going to feel? Are they going to be like, okay, doc, you were good the other 19 times, don't worry about my pneumothorax? I kind of think not. I kind of think that if you have time, we really need to learn this and do this. And this is something that I didn't learn how to do in residency or fellowship. I had to kind of teach myself, and I've had success with it. I think it's something that you can teach yourself and get better at and learn how to do and decrease the complications according to the literature there.
Yes, we've covered this as well. Google it.
We're never going to be perfect, though, and eliminate all pneumothorax. So what do we do right after we place the line? We do something that tends to drive me crazy. We order a chest x-ray to see if there's a pneumothorax there or not. We all know the literature on that. Ultrasound crushes x-ray when it comes to pneumothorax. This is actually in supine trauma patients. So it's a little different when you're talking about a good 2-view upright film, maybe in a stable patient after a procedure. But ultrasound is still just as good. So why do we walk out of the room, hit a button to order someone to come in, 20 minutes later and shoot a film, then go out and 20 minutes later upload something that you're going to look at when you've got the answer right there. You just use the ultrasound to place the line. Why not immediately just take a look at the lungs? You see sliding here on the left, the pleural line, no pneumothorax. I'm not going to explain all of this. You will probably know this, and if you don't, this is an easy thing to learn. And on the right side, you have a silent pleural line or a pneumothorax. You know instantly you've got your answer. This is a little bit different than in the crashing patient. In the crashing patient, we're just looking for big pneumothorax that would cause hypotension. In this case, I would actually probably slide my probe up a little superior and even go above the clavicle because I'd like to see if those small apical pneumothoraces that I may have caused. But you're still going to get your x-ray, right? You still want to just confirm the line is in the vein, not the artery, see where the tip is. That's fine. I'm not going to take your x-ray from you. I know that's standard care. But if you really need to use that line and you don't want to wait, do what I do. Place a phased array probe subcostally, get a good view here on the right of the right ventricle and right atrium, and do a quick agitated saline flush and watch them light up. You see that right atrium, right ventricle light up. You know you're in the vein, you know you're in the right place. You can go ahead and put medication in that line. This is not something that I've came up with. There are studies on confirming whether there's pneumothorax or not, and then also where the tip of the catheter is by ultrasound. And this is quick. You have the answer right there. It's not pushing a button, someone else coming and doing it, someone else giving you a read. You, the clinician at the bedside, can answer those questions. So Avery got her line, no complications. She definitely wasn't out of the woods yet. Her first night in the hospital, she had to be intubated. This happened on a pediatric floor, which I'm not going to go into the story about that, how much different that is than in the emergency department where we do this all the time. Needless to say, it wasn't quite as quick. It didn't happen exactly like it does for us in the ICU or in the emergency department. And then I had someone there intubating her who I had never met before. And I wanted so badly just to have an ultrasound probe like I do when I have a new intern or resident who's intubating and I don't completely trust yet. And I place it on the side of the neck because you can see immediately, you see the trachea and the esophagus, and over here you're watching as the tube goes in. And I know immediately the resident says they see the cords and boom, you see the esophagus light up there on the right. And I know right then to say, stop, pull back, go in the other hole, you're in the wrong place. Conversely, here on the left, you see the trachea and the esophagus. Again, the resident's telling you, okay, I see the cords, I'm going to pass the tube. You really don't know what cords mean to them, so you're waiting, watching, seeing what happens. Trachea lights up. I know immediately, before any end-tidal CO2 or any other confirmation, I know where the tube is. But to be honest, I really wasn't that worried about the intubation itself. Kids are pretty easy to intubate. They have pretty good anatomy. It's not that difficult. What I was worried about even more was later, iatrogenic problems that come later, like pneumonia. It took a little while from when we said she's not handling her secretions to when she was intubated. And she aspirated a little bit, so I was constantly watching, is she going to get a pneumonia? Is she going to get a pneumonia? Again, she's going to be fine from botulism as long as we don't hurt her in the hospital and she gets no other infections or sepsis. But how are you going to tell? I mean, kids in the ICU who are intubated, they're occasionally going to spike a fever every once in a while. How are you going to tell if it's pneumonia or not? What type of imaging are you going to use? If you're thinking in your mind, yeah, the x-ray that we get every day, you wouldn't be in the minority. You'd be in the majority for sure. But what about ultrasound? How many of you are comfortable with lung ultrasound for pneumonia? Anybody? A few people. Okay, more than I expected. When you look at the number, it's pretty remarkable. The evidence for this is kind of astounding. Not a lot of studies, but this kind of the biggest prospective study. 120 patients came in. They thought maybe pneumonia. They x-rayed them all. They ultrasounded them all. And look at the sensitivities here. For ultrasound, the sensitivity, 98%. For x-ray, it was 67%. Pretty amazing results.
Okay, here are two newer, bigger studies on this. We're not going to go over them, but they totally confirm the results of the prior one.
And I can hear your thoughts already. You're thinking them so loud right now that I can hear them. You're saying, okay, but this is a user-dependent thing. Sure, these 4 guys in this study, they were good enough to diagnose with 97% sensitivity to pneumonia with ultrasound, but it's user-dependent. And I got to tell you, you're right. It is user-dependent. And turns out, so is intubating. Everything that we do in medicine is user-dependent. That's why it drives me crazy when people talk about ultrasound as user-dependent. In fact, it's not just medicine. Driving is user-dependent. You know what? Life in general is user-dependent, okay? This is a picture that Mike's wife sent me of Valentine's Day 2010, right? Life is user-dependent. We don't give up on people just because they're bad at a certain point in time. They get better. I mean, is this being recorded? right. I was going to tell another story just from my personal life, but if it's being recorded, I won't. So intubating. If you're not as good as someone else at intubating, you're not going to stop intubating. No, you're going to study, you're going to practice, and you're going to get better at it. That's what you're going to do. It's user dependent, but you're not going to stop doing it. And the reason you're not going to stop doing it, and the reason why you're going to practice until you get good, is because you have patients coming in depending on you being good at it. The patients that are coming in to see you, they're not coming in to see these study authors. They're coming in to see you. So that's why we need to practice these skills that other people may prove we can do. And even if we can't do them now, we can do them. They're no smarter than us. They're no smarter than you or me. We can get as good as they can at this. So this is what it looks like. Pneumonia looks like consolidation. Some people call this hepatization. It looks like the liver on the right. That's actually a pneumonia. And you can see so well the pneumonia with ultrasound, or the lungs in general with ultrasound, that some people even talked about telling the difference in consolidation from pneumonia and atelectasis. So if you look at this screen, you see these little black areas and white areas in this lung. Those are bronchograms. And pneumonia is an infection of the alveolar spaces, the alveola, pus in the alveola. So you still get air coming in and out of the lungs. So you see dynamic bronchograms, that white shimmeriness in there.
All right, the next minute or so is such an oversimplification of lung ultrasound. There's no mention of the Blue protocol, AB profiles, or so many other things that should be discussed when discussing ultrasound that I'm cutting it out. To make it up to you, we'll play a great lung ultrasound video by Kylie Baker for you very soon on the podcast.
Along those same lines, Jim Sung did a great paper showing us that maybe we can even tell viral versus bacterial pneumonia. We can see the lungs so well with ultrasound. They were doing a study on pediatric lung ultrasound in New York City at the same time the H1N1 pandemic hit. And what they had is a great set of data of flu swabs, positive or negative, and then the lung ultrasounds to correlate. And they found these little subpleural consolidations were really good at predicting who had viral pneumonia. So this is all soft tissue here. Here's a lumpy, bumpy pleural line, and here's a little subpleural consolidation. And what they found is the patients that had that had a really, really high likelihood of being diagnosed with viral pneumonia. You can see the lungs so clearly with ultrasound that some people have actually asked the question, can we replace standard chest x-ray with ultrasound in the evaluation of the disc mutation? So if I ask you that question, can you replace x-ray with ultrasound? I think your answer should probably be no right now. All right, you can't unless you've done a lot of these. I want to be very clear about that this is a procedure like everything else, like the peripheral IVs, ultrasound-guided peripheral IVs I mentioned. You have to do these over time to get really good at them. Eventually, I think you can, but don't think that you can go back tomorrow and start doing the things that you hear about. Do them, but confirm. Get good at them over time. We need to have confidence, but we need to have humble confidence at the same time to make sure we're practicing this safely. I saw so many instances throughout Avery's course where ultrasound made a difference or it kind of could have made a difference. For example, after we took her Foley catheter out, the bladder, it turned out, was one of the last things to come back. We were able to diagnose quickly the fact that she had a lot of urinary retention and she was just peeing a little bit, not as much as we expected. So we looked and she had bad urinary retention. We were able to fix that before she had an infection from all that stasis. They placed an NG tube in after she'd been extubated. She wasn't feeding well enough still. And when the nurse did, she listened to see where it was. And she said, yeah, it's in the stomach. But the look on her face didn't convince me. I said, are you sure? She said, yes, I'm sure. I said, why don't we just confirm with something? This was on the peds floor. They didn't have an ultrasound machine. So they got an x-ray. It took quite a bit of convincing. They got the x-ray and it turned out that the tube had went down and then curled back up and was sitting right at the carina. They would have fed her right into her lungs. But confirming NG tube placement is something that you can do with ultrasound. We showed you a picture of that yesterday at Sona Wars. And we haven't even talked about the things in pediatrics that we think about. Pyloric stenosis, appendicitis, intussusception. But I can't teach you these things in 30 minutes. I didn't learn these things in 30 minutes. Instead, I wanted to bring you along on this journey that convinced me to learn these things. I know how to do these things now because I saw the difference that it could make. But again, I just want to say it one more time. You're not going to replace x-ray with ultrasound as soon as you get back. The way that you're going to learn to do these things, though, on your own, I know most of you aren't in residency and fellowship learning this. The way you're going to learn to do these things on your own, how I did, is every patient that had a pneumonia on x-ray, take a look with ultrasound, see what it looks like. You've seen 1,000 x-rays and a few ultrasounds. How are you going to be as good with ultrasound initially, even though the studies say you can be? You're going to look at it over and over. Every time you have a patient that has intussusception or pyloric stenosis, you're going to take that extra 60 seconds and look, because you know if you look at enough of those, you're going to get good enough that when a patient comes in and you don't have radiology, or it's time dependent and you have to make the diagnosis on your own, you're going to have that skill and be able to make a difference. That's why you went into medicine, to learn procedures and skills to make a difference in these patients coming in to see you who need your help. So I'm going to end with one last story about a patient that I had a little more recently. And it started with a call from EMS. They called and said they had a 2-month-old coming in full arrest. Okay, my heart sank. That's our worst nightmare in medicine. But then they said they were trying to intubate and couldn't get the patient intubated, which actually gave me a little bit of hope. These are usually hypoxic arrests, so I thought she'll arrive, we'll intubate her, we'll get oxygen going, and she's going to be okay. She's 2 months. She wants to live. They arrived. Sure enough, we were able to intubate her really easy. It was a great resident I was working with. Intubated this patient. First pulse check, didn't feel anything, but that's okay. We just got her intubated. We're getting the oxygen to her. We're getting her what she needs. By the second pulse check, I didn't look with ultrasound at first. We just want to minimize the compression interruptions. Second pulse check, we felt still no pulse. The family's there at that time, and I tell them, you're more than welcome to stay, or you can step out and we'll come get you. I was a little frustrated with the second pulse check. I was hoping we would have a pulse by then, so I decided at the next pulse check, I'm going to take a look. I'm going to get some more information, take a look at her heart. So in the third pulse check, I put the probe on her chest, had a little bit of trouble getting the window, but right as someone said, no pulse, resume compressions, I got a glimpse of this. It looked like a heart that was beating to me, but no one felt a pulse, so I didn't stop. I just got a glimpse of this. They resumed compressions. I thought, that's fine. I probably just want to see a heartbeat here. I'll get a good look at the next pulse check. So we went through another round. The next pulse check, I take another look. I know exactly where the window is. I get a good look at this. This patient has good cardiac output and ejection fraction. Great, this baby is back. And then someone says no pulse, which kind of startles me. So I feel too, I can't feel a pulse, and the resident who's kind of running, and I'm just kind of overseeing this, says resume compressions. That's the right answer, right? No pulse, resume compressions. This is a pretty simple question. Do they have a pulse? If they don't, we're going to do compressions. So I didn't stop them, but I had this horrible disconnect in my mind. What's going on here? And so I voiced it at that time because I felt pretty sure of what I saw. And I remembered a study that I had seen. I told everyone what I saw, what I thought I saw. And I told them I remembered the study. I didn't remember all the details. It was actually an Australian study, which I don't think invalidates it. But it was amazing results. Rescue or pulse palpation accuracy, 78%. That is a scary number for something that's so important. I didn't remember the number, but I remembered the gist of this article, and I mentioned it. And one of the nurses had a great idea. She said, well, the next pulse check, why don't I take a quick look with the Doppler, put the Doppler on the femoral artery. So she did that as I took a look at the heart, and we saw this again, and we heard a whoosh, 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 whoosh perfectly along with this heartbeat. We took a pressure, and the baby had a pressure. This baby was alive. I don't know how long she'd been alive, but as I walked out to go tell these parents that their child was alive, I was kind of overcome with this extreme gratitude. It's a gratitude that I work in a time where I have a tool, this technology, that, yeah, it's user dependent. Sure, we don't know exactly the sensitivity and specificity and the operating characteristics of the technology for every disease, but it makes me a better doctor. It's as simple as that. It made a difference in this patient's care, and it makes a difference in patients that I see every day. So I have that same kind of gratitude as I look out among you and see all these people who care enough about their patients to take the time and come and learn this. What I'd like to challenge you to do, though, is to continue to take that time. This is a journey. It's not, ultrasound now. This takes time. It's an investment, but it's an investment that are worth it. The kids that you see are worth it. She's worth it. Thank you for your time.
So thank you so much, Matt, for an inspirational talk. Time for one or two questions, if there are any from the audience.
That's a great point. Mike and I just kind of recorded a podcast on PE, and he made that comment about the subpleural consolidation. I gave him a hard time. I said, that's viral pneumonia. That's not a PE. And his response to that is, you kind of know what's going on with the patient. You have a little bit of clinical history. And this is a great point about ultrasound in general. If this is a patient that has shortness of breath, dyspnea, just had surgery and has a big cast on their leg, and they have other findings or cardiac exam, the RV is big, and you suspected a PE already going in, you're thinking PE from a subpleural consolidation. If it's someone who's had a cough for a month, has symptoms of a virus, then you're thinking viral pneumonia. This is the wonderful thing about point-of-care ultrasound is it's in the hands of a clinician. You're not really reading a film you're looking and taking this extra information and combining with your pre-test probability of what you thought was already going on and coming up with a decision.
We might just, we'll have time at the end if that's all right, guys. We might move on to the next talk. Thank you so much, Matt.
All right, come to SMACC. And if you're coming, join us in Yellowstone National Park the week before for some ultrasound education. Register at smacc.net.au and register for the Yellowstone course at yellowstoneultrasound.com. See you there.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Here's a sneak preview of our next episode, which will be of Sona Wars, recorded at SMACC last year.
You butt thrust. The butt out. Get it out. There you go. There you go. Good. Yep. Yep.
Yeah, man. I mean, it's magic. I sing him a lullaby every night. It's amazing. You want to hear it?